I'm Dr. Craig Escudé, the host of IDD Health Matters, a podcast where we talk about health, wellness, and health equity for people with intellectual and developmental disabilities. Hope you enjoy it. Today's podcast episode is a recording of the Intellectability IDD Perspectives webinar series. If you'd like to learn more about upcoming webinars, visit us at replacingrisk.com.
Hello, everyone. It's great to be with you here again. I'm Craig Escudé, family physician, board certified by the American Academy of Family Physicians and the American Academy of Developmental Medicine. Practiced in this field for over 20 years clinically and now work with Intellectability, where we develop and provide tools and training to supporters of people with intellectual and developmental disabilities to help them identify health risks that are often missed and improve overall health outcomes. I'm the author of the Clinical Pearls in IDD Healthcare, also an online course called the Curriculum in IDD Healthcare, and I host the IDD Health Matters podcast. I'm really excited to introduce to you a dear friend and our guest for today, Dr. Matt Holder. Dr. Holder is a board-certified physician as well, including of the American Academy of Developmental Medicine and Dentistry, which he founded back in 2019. He is also the AADMD, the American Academy of Developmental Medicine and Dentistry co-founder and past president. He's been a global medical advisor and chair of the Medical Advisory Committee for Special Olympics International and the founder of the Lee Specialty Clinic in Louisville, among many, many other things. So, Matt, do you have anything else you want to add? And welcome.
Well, no, thank you so much for having me. I've been in the field for about 23 or 4 years, something like that. And I'll spare you the rest of my CV.
Well, we're excited to be here with you all today to talk to you about something that is a very common reason that people seek healthcare for people with intellectual and developmental disabilities, and it's, you know, why is he just not acting right? What are the reasons? Something's wrong. Something's going on. I'm not sure what it is. But before we get into that, I'm going to share a quote from Dr. Holder, like we always do, and see if he can, and let him expound upon it a little bit. Because I love this quote: "Advocating and being willing to have those conversations and not give up is a real important thing for being in this field and pushing improvements forward." Matt, would you talk a little bit about that?
Yeah, you know, it's funny. It's kind of a mantra of mine that, you know, there's that saying, you know, I keep hitting my head against a brick wall, and a lot of people, you know, in people's minds, that means that you're not getting anywhere, and mine is just, you know, you just keep hitting your head against the wall until the wall breaks, and you know, which may or may not be good, but it's just sort of my mentality. Honestly, the perspective on this is both at the patient level and at the system level, because everything that we do is a level of complexity that most people who aren't in the field can't quite get their mind around. And because of that, people who you're going to be working with who aren't in the field tend to look for more simplistic solutions than perhaps the person needs. And there always tends to be this reversion back to the system that is failing the person, or the solutions that have failed the person. So from a systemic standpoint, as an example, I do a lot of work in sort of the health payment realm and trying to figure out new ways and better ways of demonstrating the value of the type of medicine we provide, and being able to fairly and adequately reimburse healthcare providers who are in this field. One of the things that's interesting is that the system keeps trying to push our patients, who are mostly on Medicaid in the US, into a Medicaid fee-for-service type system. And my argument there is, but that's the system that has continuously failed them and produced the results that we're trying to get away from. So now changing the system and changing Medicaid, I mean, that's a very tall order, but we have to keep having that conversation. We have to keep pushing, because we're not going to get better outcomes unless we force people to sort of look at things a different way. And I would say that even at the individual level, where the knee-jerk reaction a lot of times in medicine, and we'll talk a lot about this as prescribe certain things, that at first brush, maybe it looks like they need, but in reality, maybe they don't. And then you have to convince the chief of a hospital or an ethics committee, folks who may not be completely used to working with this population, to look at things in a very different way. And this is all for the benefit of the people that we serve. So that's kind of the root of that quote, I think, in particular.
Well, it's a great quote, and it's something for all of us to consider. So when there's a roadblock, for me, that means we just need to figure out how to get around it or how to move it. Not that, we've got to stop here. So I totally relate to this about always pushing forward to make change and to see things, help people see things in a different way and to move things forward. All right, so let's get to the topic today. I will say, when I was in clinical practice, there were two main, what we call chief complaints, two top reasons that I was asked to see a person with an intellectual disability. One of them was, hey, doc, can you take a look at him? He's just not eating. And the other one was, hey, can you take a look at her? She's just not acting right. And so today we're going to talk about that, hey, she's just not acting right. And what are some of the reasons? What are some of the things that we need to think about when we get that that impression, or someone presents that to us and say, hey, can you take a look at this person? He or she is just not acting right. So let's go to the first slide here. And I love, Matt, that you put this as the first slide. So I'm going to let you take it from here.
Well, I think it makes the most sense. I mean, we are healthcare, practitioners and providers, so this is kind of where we have to start. And it's funny that you mentioned the two reasons, not eating and not acting right, because sometimes it's the same thing that could be causing either one, right? I think that there are actually probably other reasons. And maybe more often than not, there might be other reasons other than medical reasons. But the reality is the medical reasons have the highest level of consequence typically. So, you hear these stories, and I've heard them more than once, of somebody who dies of intestinal rupture secondary to 3 weeks of constipation that,
nobody really picked up on and noticed. Yep.
Exactly. And maybe they picked up and noticed the behavior, and they went down and got, some sort of psychiatric drug for that, which probably made the constipation worse. But, that's the kind of scenario that we just can't have. I'll tell you the story. We had I got a call from, it was a hospital in Washington, D.C., and a family member had, they had a loved one who was put on hospice care, and the hospice folks were, withholding food and withholding hydration and withholding medication other than pain. And, it was like, okay, this person, they had basically just decided it was time for this person to die. Now, this person was mid-30s, cerebral palsy, and I'm kidding you not, the diagnosis that they gave him was terminal cerebral palsy, which I thought was just medically, if it wasn't so terrible, it was hilarious because, it's a static condition, and it probably hadn't changed for him, for the entire 35 years of his life. And the main complaint was that he was just failing to thrive. He was not eating. So there you go. He wasn't eating. And he wasn't acting right. He was no energy, low energy. Sometimes he would get worse around sunset and things like that. And they started talking about like dementia and all kinds of like crazy things. And I asked for the records, looked at the records. The guy had a UTI, and I said, oh, that's interesting. Like, why does he have, have you treated UTI? And they're like, no. Well, when did this start? Well, he came in with it. So he came in with this UTI. They opted to treat it. They just decided it was time for him to die. So I said, you know what, like, maybe you're right. Maybe he's, there's something else going on, but why don't you at least treat the infection so he's not suffering? So lo and behold, they treat the infection. 3 days later, he perks up and he's fine. He's no longer in hospice. He gets out of the hospital. He's no longer terminal. I mean, that kind of behavioral change is something that you can see. And he was nonverbal and, all the things that you kind of see in this population. Those are the kinds of things that happen, and the consequences are just dire in the medical field if you aren't paying attention to this.
Yeah, it's a terrible story, and a story that many of us probably have similar examples of. I know I do. And it really is devastating to people. And we have to see people as people first, and human beings, to treat them as human beings and treat their medical problems. And we also have to educate healthcare providers and everyone else to know what to look for. So getting to some of the things on this slide, you have pain or hidden pain or illness first. That's a huge cause of behaviors. And you think about it. If I'm hurting and I can't tell anyone what I'm feeling, I'm going to figure out somewhat kind of way to express it or make it known, right?
That's absolutely right. And one that a lot of people don't think of, dentistry. That's something that on the medical side you sort of tend to overlook. Something you have to think about: ear infections, UTIs, any type of in-vein constipation, GERD. Those are all just so common causes of pain and discomfort, and you just have to look for it. I mean, there's just no other way around it.
Yeah. Another thing you have on the list that we have to think about a lot is medications. We know about polypharmacy in this field. A lot of people are on a lot of medications. Sometimes they're needed and helpful. Sometimes they're not. And they can cause additional problems. And they can be a cause of a person, quote, not acting right.
I have seen that so many times. And my mantra for the most part is, when we're getting a new patient at the clinic, you have to question. Honestly, I think about it this way. Most physicians, and I mean most as in the vast, vast majority of physicians, have never been trained in how to care for this population. So the likelihood that somebody has gone to a physician who didn't exactly know what they were doing and prescribed a medication that they probably didn't need, and that medication continued on forever, because that's kind of what happens, those odds are pretty high. So when we get somebody at the clinic, we're going to look at every diagnosis they have. We're going to kind of question it to make sure that it actually exists, because a lot of times it doesn't. Another thing that I've seen a lot of is the over-medication issue a lot, because there is this cycle of diagnostic overshadowing that exists, but there's this cycle where there was something that was creating this behavioral issue, they're not acting right, something that was, but we missed it, but we treated it with a medication that sort of made the behavior go away. And then the medication sort of, the patient gets acclimated to it, or the issue gets worse or whatever, and the behavior comes back. And so we treat it again with a different med, and then the behavior comes back, and then we treat it again with a different med. The whole time we're doing it wrong. And after a while, they end up so over-medicated that they're just slumped over and drooling and, barely conscious, which in some ways the industry kind of is okay with sometimes, because
behavior anymore, right?
It requires less staffing. It's a little bit easier to deal with. I mean, there's some incentives there that aren't great for the person. And, but meanwhile, this person is, taking a whole bunch of meds, and they're getting these side effects, right? You're getting osteoporosis,
continuing to suffer.
Yeah, and setting them up for things that are worse. If you look at antipsychotics, and that whole cascade. This is like the cascade that I go off on all the time, is the whole antipsychotic. Because you go on there for a while, you start getting tardive dyskinesia or whatever, and you end up developing dysphagia. Sets you up for aspiration pneumonia. Next thing you know, you're going to the ICU. I mean, there's this whole cascade of, we missed the thing of the behavior. We treated it with a medicine that has long-term side effects. We ignore the side effects, and then 10 years down the line, we're paying huge dollars for something that could have been prevented a long time ago if we knew what was going on. And to me, getting back to the whole healthcare payment piece, that is where the real value of focusing on this population is, because we are spending a lot of money downstream trying to clean up the pieces of bad healthcare. And if we had a little bit more of a preventive focus and focused on the things that we're doing wrong, we could probably save a ton of money and actually improve health outcomes.
I agree with you on that point for sure. Let's look at some of the other things you have on the list here. We already kind of touched on undiagnosed health conditions for sure, and there are many different things. And we've got to remember, like you said, dental conditions. You know, medical doctors aren't used to having someone present to them that has a dental problem, because most of us would know to go to the dentist if we have a dental problem. But as a medical healthcare provider, if you see someone who's, quote, not acting right, think about oral health conditions as well too, and maybe refer them to the dentist. I would certainly say. What you mentioned? Go ahead.
Well, there's a part of that is a little disturbing too, because if you ask a lot of family members or folks who, if they have a dentist, the answer is often yes. But a lot of our folks end up getting taken to the operating room for routine dental care because they have behaviors in the dental chair, and that tends to be what a lot of untrained dentists do. But the bottleneck in that equation is access to the operating room. So you're like, in a lot of places, a lot of cities, it might be a year and a half before somebody is able to even get into the dentist office. So sometimes you might say, oh, you have a dentist. And if somebody says yes, then you sort of both check the box and kind of think, well, the dental stuff must be taken care of. But it might be that they're sitting there in dental pain, and they've been sitting there in dental pain for a year as things have gotten worse, and they're not going to see a dentist for another 6 months or so. So it's just something you kind of need to dig into.
Yeah, great point. So you also have on the list allergies.
Yeah. It's something, well, I live in the Ohio Valley. And so here is like Allergy Central. And so every spring, we get sort of a rash of, behaviors that pop up. And sometimes that is, due to other things, but sometimes it's just simple seasonal allergies. And so somebody has a sinus infection or again, it sort of goes back to the hidden bit of pain. The other thing is sometimes you've got food sensitivities. That's a little different than an allergy, but certainly it's something that comes up a lot, especially in the autism world, with gut issues and things like that. So those are a little bit harder to figure out, but you look for patterns. That's kind of what you do when you're analyzing behaviors.
So nutritional issues. I don't think that's something that we all think about that often.
This one, so one of the actually original founders of AADMD, his name is Dr. Phil May, and he's in North Carolina. And he's retired now, but he told me this story and it always stuck with me. And the fact is they've discovered more errors of metabolism than, this original story, but it was from his early days as a doc. And he was treating a patient who they couldn't figure out what the cause of her behaviors were, but he kind of looked at the situation, and what he realized was that she had been born 2 years before they started testing for PKU. And so she was never tested for it, but turns out she had PKU. So he tested her for it. And you can't reverse the damage that's been done by the PKU, but they obviously changed her diet at that point because phenylalanine was an offending agent. It continued to offend her, her metabolism. And so once he found that out and changed the diet, suddenly the behaviors got a lot better because her brain was no longer bathing in that toxic soup. So I think the same kinds of things can exist in, other areas of metabolism that exist out there. Maybe that might be undiagnosed.
Absolutely. Hormones.
Yeah. Well, look, everybody kind of goes through hormonal changes as they age. And so this is something that we see. You kind of forget about it with our patient population, but you know what? And some of it is our patient population classically didn't live long enough, for example, to go through menopause or, things like that. And so looking at just what naturally happens, and it could be thyroid also is another, it doesn't have to just be anything the ovaries produce, but any type of hormonal issue, can be something that you need to really look at. And certainly there are syndromes, and this is why I go back a lot on trying to figure out if there's a genetic cause to, like when we're looking at patients, a lot of times, of course, they come to you with a diagnosis of intellectual disability, or autism or something that is kind of very broad. And a lot of times they don't have an underlying genetic diagnosis, but maybe they do. And so one of the things that I think is very useful and helpful is to get a good modern genetic workup for folks. So you can look to see what kind of issues they might have, and are they predisposed to things like hypothyroidism, like Down syndrome as an example. So those are kinds of things you have to look for.
So, you mentioned that in years back, people with IDD didn't live long enough to go through the menopausal changes or experience other things like hearing loss or vision loss that we see as we all get older. And I talk about the hearing and vision in particular being causes for adverse behaviors. If you want to expand a little bit more on that as well.
Yeah, I just remember with my days of Special Olympics, how many people had hearing or vision issues, and the numbers were pretty staggering. And even the folks that had vision issues but they were wearing glasses, what they found was that a staggering number of people just hadn't had their prescriptions updated, and same with hearing loss. And so it's not just to screen or not to screen once in a lifetime, but also to make sure that we're continually checking to make sure that we've updated what we're trying to do to help correct it.
And what happens to many of us when we hit 40? We all of a sudden have to hold the menu a lot further away. So think about that in a person that you're supporting who maybe enjoys doing some sort of activities at their desk or reading or doing things or crafts or whatever it is, and they can't see it anymore. So they may become frustrated. They may lose interest in that particular activity, and it all has to do with the fact that they're just not able to see it very well. So sometimes it can be very simple things like that. We just have to think about them. We need to know about these things.
That's exactly right.
All right, let's pop into another category here and talk about environmental and social triggers as a reason a person, quote, doesn't act right.
Yeah, this is such a big one, and maybe this might be even bigger than the medical one. I mean, just in terms of sheer volume of things. A lot of times, when we encounter, quote, new behavior, that to me is sort of like a trigger, because what I'm looking for is, well, what is a new change? And a lot of times that new change is something that's happening outside of the medical context. It's happening in the home. So this might be, it could be honestly anything happening around the home, right? Maybe there was a preferred caregiver who, had to leave for some reason and is no longer part of that person's life. And, that's maybe that's an issue. Or yeah. I mean, it's exactly, maybe they've now, moved, maybe they had to move, maybe they had to get to a different program. There's, all kinds of different things. Maybe they just don't like their roommate. I certainly, and I guess this is one that I think is important to talk about, because I'll say, in our clinics, we serve basically the age 13 and up. And I'll say the highest risk time for our population, I think, with behaviors and all that, probably, as you kind of might expect, but like low 20s until probably low 30s. The teen years all the way up probably to low 30s is kind of the higher risk area for that. And, if you think about that, it's also the high risk for neurotypical population too. I mean, that's when, people have lots of energy and lots of hormones and lots of like independence and maybe not quite as much judgment as they ought to have. And there's this push, I think a very natural thing that happens to every person who's been living at home, is at some point they want to not live at home anymore with their parents. They sort of feel like, I'm an adult, I want to live somewhere else. And I don't want to be, the baby of my parents all the time. And this is a really hard thing to confront when somebody's 25 years old and mom and dad who have taken great care of this person for their entire life and are very much still wanting to take care of this person. But maybe that person doesn't want that anymore. And they really want to be out on their own. And that's a tough one. But I think that's something that we see a lot. And I guess the classic version of this story is that the person's been in high school, they're 18, they're 19, they're 20, they're 21, whenever they age out of school, and all of the pediatric programs that they were in, and they had this nice, stable sort of environment that the parents had figured out all the way up until the age of 21. And then suddenly, as you know, they fall off the cliff.
Yeah.
That's what it is. And all the programs change, everything, you know, their friends go away. You know, maybe their siblings have moved out of the house. Like, everything changes at that point. And then what we see a lot is the family starts, the burden of caring for this person, where they had this big support network and all these programs, now starts to become more of a familial burden. And the parents start to get stressed out, and they start to burn out. And then that creates more tension in the home. And it sort of have this like spiral of things that just aren't great. And so to me, like, that's something that I see a lot of. And it doesn't always mean the person has to move out of the house, but what it does mean is you have to help the family restructure their system of care that they probably weren't quite prepared for changing. And then, you know, and a lot of times you can solve issues just that way.
Yeah, that makes a lot of sense. And maybe even, you know, preparing families earlier on for these transitions that you anticipate that might be happening can be a way to make it smoother for everyone, including the person with disabilities. Looking at some of the other things here, advocate demands that are exceeding skills. If people are being asked too much of, or to do something that's too difficult, that can be challenging as well.
Well, I mean, it's just like what you mentioned with vision, right? I mean, you know, one day I can do my job, or one day I can do this task because I can see it, and then suddenly I can't. Well, I'm not excited about doing that thing anymore.
Yeah.
And, you know, and then if you keep asking me, well, I'm going to tell you to, you know, go jump in a lake.
Leave me alone in a different way, maybe.
Exactly. But I think I want to go back to the thing that you said about, you know, making sure that you get in early with families and have this discussion, because even though we see it like that 20-year-old, you know, 15 to 25 sort of transition period into adulthood tends to be tough. Like, the harder one, and this is it, and it's fine if people want to take care of their kids and keep them in the house, that's great. But there does come a point where the parents are now 75, 80, and that's a whole different conversation. But you have to have that, because and the way that conversation goes for us is, look, like, you want to start thinking about this now, because you can now see that this is going to happen. And what you don't want is to be, you know, well, I fell and broke a hip and I didn't think about any of this stuff, and now my son, who's, you know,
you're in an emergency situation almost. Yeah.
Right. And then everything's falling apart and you don't have the tools to deal with it. Right. So you're absolutely right. It's one of those things that we try to get on early.
Yeah. And, you know, and the third big bullet point here, conflict or lack of support and feeling ignored, misunderstood, disrespected. I think that really probably is under-recognized as a cause. And to me, this speaks to the importance and the need for understanding how to support people in person-centered ways that takes into account what they want for their own lives, and let them have some positive say-so in their lives to the you know, the maximum ability that they can, and always balancing what other people think is important for them with also what they want for their lives, and that can help with some of that.
I think we hear that over and over again from self-advocates, you know, that my doctor doesn't listen to me. The people around me don't listen to me. People try to baby me, you know, that kind of stuff. And we really have to work on listening to folks with, you know, as they tell us things, and trying to give them the life that they want, you know, trying to work with them to get them to where they want to go.
Yep. All right, we could probably talk about each one of these things for an hour.
Yeah, I know.
Let's move on to sensory processing differences.
Yeah, I mean, I think this is a pretty easy one, you know, in a sense that, well, it's easy. It's fairly common, you know, and certainly as we, you know, hear more about autism and, you know, things like that, you certainly see more of this. The hard part is that the way that it manifests, obviously, for each person is unique to that person. And so as an example, something that you might do to accommodate something that you might think like, oh, well, let's have the ability to, let's keep the lights low because, we don't want to like hyper offend, people who are sensitive to light. And then you'll find out as soon as you do that there's a whole group of people who really like it bright and really want it that way. And they'll tell you, we had something that we put in our office, sort of like this brown noise machine. And we did it because the majority of our folks, like it helped to sort of like buffer any sort of sound. It was great. But the problem was like, there were a couple of folks who they heard it. Once you hear it, like you can't not hear it. And so they would be like, oh man. So thankfully, like we figured out how to turn it down for those people. But like, you have to really try to like tailor your approach to folks based on these sensory differences.
And I would be one of those people. I don't do well with hearing some background noise. It gets to me, and that's really the point. We are all different, and it's learning how to recognize the differences and different sensitivities and sensitiveness that others have, and then recognizing that can be a reason that a person, again, quote, is not acting right because of sounds or lights or textures or food preferences or textures of food or whatever it might be. And the other side of that is from overstimulation, it can be understimulation or being very bored or not having enough to do can cause people to figure out things to do like, oh, let's break this or let's throw this and see what happens, right?
Yep. And I think that's one of, at least the behavior analysts have taught me, always look for the pattern, right? You've got to, like when you're hearing about behaviors, one of the things that tends to differentiate medical things from other things is that if it's pain, like that pain's probably always there. Now, maybe it's worse if you're chewing and it's dental, but a lot of times it's that. But if somebody comes to me and they're like, look, every time this person gets in the van and then they get out of the van, like all hell breaks loose. Well, okay, but it's only that, then okay, then there's something about the van that we have to deal with, right? What's that, right? It's that thing. And so when you're looking at behaviors, I think, and especially when it's sensory, because I can't tell how you feel about something, especially if you can't explain it to me, like I can't tell. So it's sort of a process of elimination where you have to look at the pattern and really try to narrow it down to what's happening in the environment at that point, and then really try to put yourself in that person's shoes to figure out, okay, if I'm there, then what's going on, in this situation. And that's I've had lots and lots of folks where we've been able to figure out that it was just one particular thing about that environment, and it was a sensory like fixation almost. And it kind of just drove them a little bit crazy. So we dealt with it.
And, you said this several times, but I just want to drive it home. It's looking at the patterns and the context of behavior that can really help you figure out a lot of these things. So always, be aware of patterns, documenting when things are happening, when they're not happening, what's happening around those times. They can really be helpful to you figuring things out. Now, I love the title to this next slide. When I was going through the slides, I was like, this is an interesting title, and then I got it. So I love this. Everything else you can think of before the next slide. At first, I thought it was a placeholder, but you meant to put this there. So I'm going to let you.
All right. Well, I guess the joke is really the next slide, right? That's the punchline. But at this point, once you've gone through the environment and you've thought about sensory things, you've gone through your medical things, right? You're kind of left with, okay, let's broaden the things that we're thinking about. And I guess I'm going to try to do this without mentioning what the last slide is, but
you can't mention it. You can't spoil it.
Yeah. But, this is where I start, looking at things like that are psychologically driven, that are, any type of, it might fall into changes in environment or whatever, but, these are things that are going to affect the psyche of somebody, but are not things that you would necessarily treat with medication necessarily. These are things, look, grief, right? If you have loss, then obviously that's going to produce that. If somebody just lost their mother, like, that's going to be really tough on them. And you would probably expect things to happen. and that could go on for a while.
And I think it's important to say that some things are normal. It's normal to feel sad and less interested in activities when you've just lost someone, for instance. And we can't fix normal per se. We always want to make sure it's not something else that is fixable, but some things that's an appropriate response, right?
It absolutely is. And, we've had patients who, like, for example, would only see their parents on major holidays. And so it's just sort of the way that their life was, because maybe they were out of state or who knows. But it was like the first Thanksgiving that went by, and it was every Thanksgiving after that, right? Because that was the thing that triggered the grief of the loss and the loss of the expectation that mom would be here, and mom's not here because it's now, and that's a really tough thing. Abuse, I think, is also, it has to be mentioned. It is, any report that you see on abuse in this population is staggering. It's terrible. It's really sad how much abuse happens.
Depending on what you look at, there's about a 7 times higher rate of abuse, sexual abuse, and other abuse in people with intellectual and developmental disabilities compared to those without. So you always do need to think about abuse as a potential reason a person is, quote, not acting right, for sure.
These folks are so vulnerable, and there are signs, but it's just something you really have to think about. Dementia, I put that on the list because it is something, as the population ages, certainly it's something to think about. Now, for me, dementia is something that I think is very important. It's also something that I'm ruling out a whole bunch of other things before I go, well, it looks like the brain's just deteriorating, right? Because once you have that, then that explains everything else that goes wrong from now on. And so that's something you don't want to go lightly into.
Excellent.
Seizures, I think, is something that, there are late onset seizure disorders, right? That not everything happened, at the age of 4 and now you have seizures from now on. You can start developing seizures and absence type things, and at any point in time. And so that's always something to consider. That
it can look like all kinds of different things. They're not all somebody, losing consciousness and stiffening up and then shaking and falling to the ground and shaking. They can look like a weird arm movement, or even a loud vocalization, or a weird facial grimace or something like that, or a person not responding to you, not listening, quote. Those all could be seizures.
That's right. And we actually had a very interesting case not long ago, which was post-ictal. They called it post-ictal psychosis. I don't know if we could have proven it was psychosis, but basically what happened is this person would have a seizure, and it was more of an absence type seizure. So it wasn't even obvious that it was happening, but we were able to find it on EEG. But after they would have their seizures in the post-ictal phase, after they were sort of like out, they would wake up and then they would go ballistic. And and so we saw them do this in our office a couple of times. One time they ripped the TV off the wall. Like it was something very interesting that I hadn't seen before. It was just this like hyper aggression that happened after the seizure activity. So again, it can present in a lot of different ways.
Absolutely. Lack of activity, loneliness, stress. You want to touch on that?
I think it is just all of, again, going back to the sort of the psychological things, right? Loneliness, stress, trauma. These are all things that don't necessarily, they could, I guess, involve medical intervention or pharmaceutical intervention, but they don't necessarily. It's quite normal for people to feel lonely or stressed out or, traumatized by something. So you have to look for those things. And, again, I'm getting down toward the end of the list. We can go to the last slide because this is the thing.
So
right, there you go.
We thought of everything else before we thought of what you're about to see. But
right, exactly.
The person not to, quote, act right as well.
Right. And so the reason why this is sort of the last one is because in most physicians' mind, this is the first thing that they go to.
Yeah, and we're talking about psychiatric problems, psychiatric concerns here.
Exactly right. It's psychiatric issues. So I put psychosis. I put the psychosis, anxiety, depression, sleep hygiene. These things are, look. I think a friend of mine did a great study on people going to the hospitals, and they found something like 11% of the time somebody with IDD is going to be diagnosed with psychosis. And which means that in theory, 1 out of every 9 people with IDD have psychosis, which is insane because that is actually not in any way true. But somehow we're giving that diagnosis. And then why are we giving it to them? Because we're going to give them an antipsychotic because we're trying to control the behavior. That's why it's happening. It's the tail wagging the dog. There's this thing. So we opened up a clinic in Tennessee, and I'm sorry, Tennessee, I'm gonna use this term, but we sort of coined it when we were there. We called it the Tennessee Tanker. And I'll say it is not in any way unique to Tennessee. It's in every state that I've ever been to, any country I've ever been to, actually. They do the same thing. But this is that classic, diagnostic overshadowing or medication loop that I told you about. And what we would see, we saw the pattern so much. 2 antipsychotics, right? 2 antipsychotics, 2 benzodiazepines, 2 anti-seizure drugs that, in a person who doesn't have a history of seizures, 2 sleep aids, right? So now you're on 8 different medications, and then probably they're on an ADHD med and they're on an antidepressant. And so and the thing is, I've seen this pattern so much that I gave it a name because it's just like that loop of, well, we tried one antipsychotic, so let's do another one. Well, I guess we shouldn't go to a third one. Let's give him a benzo. Well, we tried okay, let's do another one. Oh, probably shouldn't give him a third one. Let's do something else. And by the end of it, you've thrown the whole DSM-5 at the person, and they're on a zillion drugs. And frankly, you're probably chasing side effects of the drugs you were giving them in the first place. So this gets back to kind of what I was saying, in the very beginning, which is there's so much preventable polypharmacy, so much preventable long-term side effects. And it really kind of starts here with the misinterpretation of all of these other things that we talked about and a very quick labeling of psychosis or anxiety or depression. There are times when I just scratch my head and I'm looking at somebody who is, nonverbal, not, I guess, the very complex, let's just say a very complex scenario. And they walk away from an ER with a diagnosis of, ADHD or something. And I'm just wondering, like, how did you do that? You explain to me how you diagnose that this person, has attention deficit, or, that they're depressed. How do you do that? And it's not to say that you can't try these things and there aren't other signs, but the amount of times that I see this where the professional that did it clearly did not do any of the homework that you would need to do in order to make these diagnoses, it's disturbing. And I think once you start getting into sleep hygiene, it's so important. It's one of those very much overlooked things, but then you can also overdo it. So
I love your asterisk there too, that warning, this is where most preventable polypharmacy begins. That's certainly true. And I don't want to say that people don't have mental health issues, that people they certainly do and can, just like everybody else can. But I would certainly agree with Matt on this point, that it is overdiagnosed and many times in an effort simply to put someone on a medication to stop the behavior. So we have to be aware of that and be concerned about it. Matt, the information we covered here is invaluable. I wish I had known this stuff when I started in my career early on, but unfortunately, we have to learn things the hard way sometimes. And it's such a wonderful opportunity, though, for us to be able to sit here and hopefully share helpful information with the hundreds of people that are on this webinar. And thank you for being here, being on this webinar. But it's great to have the opportunity to share this information, and hopefully it will help people that they support.
I'm Dr. Craig Escudé, President of Intellectability. State developmental disability agencies, managed care organizations, and providers across the United States use Intellectability's health risk screening tool, e-learn courses, and person-centered training to improve health equity for people with IDD. Visit replacingrisks.com to learn more about how you can employ these tools with people you support.
We've got a few questions here, and I'm going to start off by saying, Matt, they're not easy questions. But so because they're not easy, I'm going to let you answer them. All right. So
thanks.
Here we go. What would you do when doctors are refusing to see a person who is their own guardian until they get guardianship because the doctor feels like they're not capable to sign for themselves.
Oh, wow. Okay. So that's a good one. Okay. Let me preface this by saying I'm not a lawyer and I'm not giving legal advice in any jurisdiction whatsoever. But I'll tell you kind of what we do. In most states so that's a very valid issue. So, people turn 18 and by default, when you turn 18, you make your own decisions because you're an adult. And a lot of families overlook, certainly there is a subsegment of people with IDD who cannot make their own decisions, at least in the medical sense. So one thing that I like to differentiate, boy, I could go on for a long time, Craig. I'm going to try to make this a short answer. So one thing that I try to differentiate first off for people is the difference between being able to give informed consent medically and all other decisions in the rest of your life. It is two different parts. And this is the first thing that you have to get people's mind around, which is you can still, because a lot of families, they don't want to take away somebody's rights, and advocates, they don't want to take away somebody's right to say, hey, I don't want to do this, or I want to go here today, or whatever. I don't want to have all my decisions made for me. When you are saying you can't give informed consent in the medical context, all you're saying is that you don't meet this much higher bar of, I understand the risks and the benefits of doing something. I understand the risks and the benefits of not doing it. And so first, mentally, you have to delineate that for yourself and for other people. In most jurisdictions, in most places, there are rules in place that kind of protect the medical professionals from doing the right thing. And so if we encounter somebody who they can't give informed consent, but and we've started down paperwork, but clearly they need medical help now, or something is going to go bad if we're not doing it soon, then typically what we're going to do is we're going to work with the people we're going to work with them first off, if, to the extent that they can contribute to their own care, we're going to work with them. We're going to involve their family or somebody who is close to them who we know has decisional capacity or, can give informed consent on behalf of that person. Somebody who has a vested interest. So, typically it's going to be a parent or something like that. And then at that point, we're going to do what needs to be done for that person. And frankly, that is, in my mind, it's the right thing to do for the parent or for the patient. I don't want to let bureaucracy get in the way of a good patient outcome. And I don't want us to be afraid, oh my gosh, we might get sued, you also might get sued if you don't provide care to that person. So let's just, get it done. And I think, one, I've never seen a lawsuit around this, and I've been in this for a while. I think the defense is very defensible. Look, we identified the informed consent issue, that we're going through guardianship, like the paperwork's in process. We put all the right steps in place. We're talking with the people who would be making that decision anyway.
But this person needs help.
But the person needs help, right? I don't think there's a jury in the world that's going to give you a hard time about that. But that's what we would do.
So, and if the physician is not comfortable doing that, the key really is to educate the clinician. So can you find the laws in your state? Can you provide that clinician with information to help them feel more comfortable in treating that person? So before we go on to the next question, which might be slightly easier, but not much, I want to remind everyone that there are handouts in the handouts tab in your control panel. There are 3 of them in there. One of them is a handout that comes a couple of things from the clinical pearls in IDD healthcare about medical causes of behaviors in people with IDD, and the other one is dental causes of behaviors in people with IDD. And there's also a little bit more information and a link to the survey. We really want to hear from you about what you thought about this webinar and ideas for future webinars. The third handout, I have it in there. It's a recently released white paper on optimizing home and community-based services and healthcare spending at a time of Medicaid cuts. I think this is a really timely topic, so I wanted to include that in there as well too. So please download the handouts while we get to this next question. And Matt, if you're okay hanging on for a few minutes, I know we said it was a 45-minute webinar, but we got a couple of good things to talk about. So
yeah, I'm happy to keep going.
All right. So this person says she works, and there's a couple of questions on this topic, so I'll try to put them together. A person works in a community supports, and she thinks that one person that she's supporting is probably on too many medicines, and they're often given meds to, quote, fix the behavior. How do I communicate this to the doctors in a way that they will listen to someone that is not a doctor?
Okay. Let me give you my rule of thumb. I'm going to be pretty brutal on this one, but this is my rule of thumb for family members. I've had this conversation with many family members, which is if your doctor doesn't listen to you, get a new doctor. Big period. The reality is that unless that doctor has 20 years of experience in the IDD world and, has seen it all. And even then they should be listening to you because they ought to know at that point that they should be. But look, doctors kind of have this reputation for not necessarily being the best, when it comes to interpersonal interactions. Some are better than others. What I can guarantee you is that most of the time, the doctor has had no formal training in working with this population. And so what you need as a parent or somebody who cares about people with IDD is a doctor who is unafraid to learn from a de facto specialist in this area. If you are the parent of a child who has Phelan-McDermott syndrome, I guarantee you that doctor probably has never heard of it and probably has no idea what to do with it. And you know a heck of a lot more about Phelan-McDermott syndrome than that doctor. So if your doctor's not willing to listen to you about that, just move on. Go find another one because you're not working with the right person. And I hate to be so blunt about it, but that's really my answer.
I don't disagree with that, but I'm going to take a step down in that and say, if you have a doctor who maybe doesn't know about it, but is at least open to learning and having a cooperative relationship, then capitalize on that and provide information and help that doctor become more comfortable. And that the book Clinical Pearls in IDD Healthcare, the reason I wrote that book is specifically to empower family members, direct support professionals, nurses who work in the field with information written by a physician who knows this field to be able to provide that to healthcare providers. And there's a number of different topics on it. For instance, the one you see here on the screen, medical causes of behaviors in people with IDD. It was meant to say, okay, doctor, here, I need you to rule out a medical cause of this new behavior we're seeing. Here's a list of potential behaviors and what they could be causing. Can we look at all of these things and at least evaluate this person for all of these things? And while it's unfortunate that you might have to do that as a supporter because the doctor should have been trained on these things, it still is an opportunity to provide some training, if you have a clinician who's open to those things. And related to that, here's another question. How can a family member tactfully educate a provider on how to best interact directly with the intellectually disabled person rather than talking past them, directing conversation only to the caregiver? That's such an interesting thing. And it's funny that you would ask that of somebody who only does IDD, because in my clinic, we just train everybody to do it. And we probably actually don't ever have to have that conversation with somebody because we inherently know. So my advice though, however, is to talk with the physician, just say, hey, look, and maybe take them aside. If you're there with your son or daughter and maybe take the physician aside and say, look, you know what, Johnny really likes it when you talk to him. And when he feels like he's part of the conversation, like just say it, like he really likes it, and oftentimes, because a lot of times the docs they don't have a lot of time. The system's not set up for them to spend a lot of time. They're in there to find the information. They just want to know what the deal is. And so they're going to go to the source of information that can quickly give them that information. And it's not personal. And they want to build rapport. Like we're all taught in medical school, build rapport with your patient. So they want to do that, but they have this scenario where they have to get information really quickly. So they're probably just going to turn to the parent and just start talking, completely unaware that they're not, building rapport with the person who they're actually trying to treat. So I think it's just as simple as that. Just, what? Johnny really loves talking with the audience. It's
the thing he loves more than anything is being here, that and having that conversation, feeling part of the conversation. And 9 times out of 10, you're probably solved the problem right there.
That's a great way to do it. A great suggestion. There are so many questions, and I tell you what I'm going to do is take these questions and kind of put them together, and maybe we can do a webinar based on some of these topics. We can do another one based on some of the topics that I'm seeing in questions, because we just won't have time to get to them all today. Matt, would you join me again another time to do that?
Absolutely. Anytime you want, Craig. This has been wonderful. I absolutely love it.
Great. A few other things to tell you about. We do have an e-learning course that anybody can sign up for, that you can take, called Actions Speak Louder Than Words. And it's helping us as supporters and family members and people who work in the field to recognize so many behaviors, and that they're actually signs of common underlying treatable medical conditions. So we've got that e-learning course that you can sign up for on our website at replacingrisk.com. We'd love your feedback. Again, there's a survey link in the chat. There's also a survey link in one of the handouts. We'd love for you to take that. And I'm going to shamelessly plug the IDD Health Matters podcast again, because I think it's a great place for you to get information from leaders and movers and shakers and DSPs and family members and nurses and physicians and state directors, and even people like Dr. Holder here, who's been a guest on the podcast, have joined us. So I would encourage you to take a listen to that as well too. So with that, we're going to close out. Thank you so much again for joining us today. We welcome your comments. And Taylor, will you close us out here?
All right, thank you so much, Dr. Craig Escudé and Dr. Matt Holder. We hope you enjoyed this presentation and that it inspired you with ideas. If you'd like to explore those ideas with our team, we're here to help. Request to connect with one of our sales representatives to discuss ways that Intellectabilities tools and training services might support you and your organization. Again, please take a minute to fill out our short survey and have a great rest of your day.
Thanks, everybody, and thanks again, Matt, for joining me.
Thank you so much.
The IDD Health Matters podcast is a production of Intellectability. Learn more about our health risk reduction tools and training for supporters of people with IDD by visiting replacingrisk.com.